Good evening, everyone. My name is David Lauder. I'm one of the advisors here at the DDU, and thank you for joining us this evening. We're going to be speaking to you about record keeping. Before I begin, if possible, we're going to try and leave the questions towards the end. That you guys should have access to what's called a Q&A box. So if there's any questions that come up during the course of the presentation, if you could put them into the Q&A box, I'll get to as many of them as I can at the end. So just very briefly, just to explain who I am, I'm a dentist. I qualified in Newcastle in 2002, worked in general practice in different parts of the UK and Australia. I did some restorative training at the Eastman. I did some implant training in Belfast, and I did the MJDF at the Royal College of Surgeons in 2013, and I joined the DDU in 2015 as a full-time advisor, and I've got a master's in medical law. So the aims and objectives, this information will be provided to you along with your CPD certificates. But what we're going to do is we're going to try and discuss the importance of keeping records and how to do so well. We're going to talk about the standards that are set by the profession in respect of record keeping. We're going to talk about the purpose of records and what the expectations are, and think about the different ethical and legal requirements. And at the end, hopefully, you should have an understanding of why clinical records are necessary, as well as what makes up an ideal record. And hopefully, we should cover GDC's development outcomes A and D. So some of you may be familiar with this scene. I certainly am. A couple of practices that I worked in, this is how we did our clinical record keeping. Some practices still now, this is how they do keep their clinical records. More commonly, I suppose these days practices will have computer records. Interestingly enough, the standards are the same in relation to both paper records and computer records. The expectations are the same, and but with both, as this slide sort of hints at, the expectations can feel like a lot. It can feel like a big ask, considering everything else that we need to think about as dental professionals when we're treating our patients. Staying on top of clinical records and satisfying all the requirements that we're aware we need to can feel like an ever-growing task. But hopefully this evening, we're going to talk about some of the different ways that we can approach it that hopefully will make things feel a bit more manageable. So these are the topics we're going to cover. We're going to talk about the purpose of records, what the GDC expects. We'll talk about GDPR, and then we'll talk about what makes up an ideal record. So what's the purpose of records? Primarily clinical. They give us an accurate picture of the patient of the care and treatment needed. They help structure our thoughts and decisions. And importantly, by the way, they can also help illustrate to a third party what our thoughts were at the time and how we reached our decisions. And a good example of that might be that if, let's say, we've got a patient who lacks capacity for whatever reason, and we think we need to make a best interest decision, it can be helpful to write your clinical records, actually illustrating what your thought process was, as in order for you to reach that decision as what you thought that best interests, what was in that patient's best interests. Because it can be very patient specific. There are different factors that you need to consider in relation to capacity and best interests. And if your records actually illustrate what your thought process was at the time, it can put you in a good position if that decision is ever questioned in the future. Remembering, of course, that that first of all may never happen, but if it does, it might be many years down the line when what was in your mind at the time may no longer be fresh. So records are, of course, obviously a good communication tool between dental professionals and others providing care, and of course also between dental professionals to other dental professionals, both within the practice and outside. And of course, they're a good aid memoir for ourselves as we're going through a treatment plan, looking at the records of previous appointments is a very important way of structuring your thoughts at the beginning of that next appointment, so you know where you are with that treatment plan. So they're primarily clinical. And it's the secondary purpose is dento-legal. This is almost a bit of a trick question because, you know, in the past when I've given this presentation in person and I've asked the audience what the purpose of records is, some people will say dento-legal, forgetting, of course, that the primary purpose is clinical. But yeah, they are of course of secondary importance from a dento-legal perspective. You know, in relation to professional negligence claims made against us by patients, terms of service claims in relation to, for example, NHS claims made by patients against third parties, and of course an audit tool for us. But the reason why, as I say, this is a bit of a trick question is that counterintuitively, if we remember that the primary purpose of records, clinical records, is clinical, that serves us better from a dento-legal perspective. If instead we approach clinical record keeping primarily, you know, for the purpose of dento-legal evidence, we can end up shooting ourselves in the foot. And I'm gonna cover a couple of reasons why that's the case this evening. But many of you may feel this, that, you know, because of the dento-legal climate, and certainly the perception within the profession of the increasing dento-legal climate, you know, increasing complaints, compensation payments, legal costs, increasing regulation of the dental profession, you know, we can lose sight of the fact again that the primary purpose of records is clinical, dento-legal is secondary. So I'm going to give you all a moment just to read this. This is a quote from a clinical advisor instructed by the GDC to give an opinion of a registrant's records. Some of you may know already that usually when a concern is raised to the GDC that relates to clinical concerns, the GDC will routinely instruct an independent dentist to provide a report, and based on that report, they'll decide how to proceed essentially. So if the report doesn't really find, you know, many concerns, they might decide to close the case at an early stage, or instead they may refer the case to the first sort of significant step, which is called case examiners. And one of the unpredictable aspects of a GDC investigation is that the independent dentists who write these reports, they can vary in how sort of critical or otherwise they can be. But the reality is that, you know, record keeping concerns are a very, very common part of GDC investigations. They're a common allegation, it's called. So if the case is referred to case examiners, that first sort of significant step, the registrant will be asked to respond to certain allegations, and the common allegations that, you know, are raised by the GDC will include record keeping. It's a very, very common allegation to be made by the GDC. So the question is, of course, that, you know, writing records and, you know, ticking all the boxes metaphorically that we need to tick in relation to, you know, clinical record keeping is time consuming. You know, considering everything else that we need to be doing in the appointment that we have with our patients. So the question obviously can feel at the time, can I afford the time to do this? But the important thing to remember is that if, you know, taking that time at an early stage ends up avoiding problems, for example, with the GDC, you'll end up saving that time further down the line. That the reality is that the vast majority of GDC investigations don't progress to a hearing, for example. But even if they don't progress to a hearing, even if it was to just go to case examiners and is closed at that stage, it can take a long time, and it could be very stressful during that period. So it's worth looking at the time spent keeping records during the patient's appointments or during the clinical day as a good investment in our time overall. So what does the GDC expect? We'll all be familiar, I'm sure, with GDC standards for the dental team published in 2013, and they've got a specific principle 4, maintain and protect patients' information. You must keep contemporaneous, complete, and accurate patient records. We're going to go through some of the standards now. Have a look for the words must and should. There's a couple of examples within these slides of how the GDC use the word must and should interchangeably or at different points. And of course, there's less wiggle room with a must than there is a should. Worth bearing in mind. So you must make and keep complete and accurate records, including up-to-date medical history, radiographs, consent forms, photographs, models, audio and visual recordings. Worth bearing in mind if we're doing remote consultations, for example, it would make up a recording of that would make up part of the clinical record. Lab prescriptions and referral letters all make up part of a patient's clinical record. It's not just what's on the actual computer system as a PDF if it's sort of printed out. The actual referral correspondence externally would make up part of the patient's records. Record as much detail as possible about the discussions you have with patients, including evidence that valid consent has been achieved. And just to let everyone know that we've done a separate webinar on consent, which you'll be able to watch through our website. And those who have watched that will know that in relation to consent, this is a key point. The actual the entry in the records of the two-way discussion that we have with a patient in the process of achieving consent is the best evidence from a dento-legal perspective. So it's a very important thing to include within our records. Must ensure that all documentation records your works clear, legible, accurate, and can be readily understood by others. I'm going to give you some examples of this later on. If you need to make any amendments to a patient's records, you must make sure that the changes are clearly marked up and dated. This is quite important in the context of trying to avoid more serious accusations down the line. It was perhaps more sort of obvious when our clinical records were purely handwritten. So let's say if you needed to make an amendment to a patient's records, let's say you had to change something, the expectation was that you would put a line through the original note, date it, and write the addition. The same applies now in the sense of if let's say you feel you need to make a retrospective amendment or an additional entry to a patient's records for whatever reason, it's very important that you just make very clear on the notes that that's what you're doing. You're not trying to make it look like no amendments have been made, because the reality is, like I've had 2 GDC investigations over the years now, where in one occasion we've instructed an IT expert, and in the other occasion the GDC instructed an IT expert, and their job was to establish whether or not the registrant had amended the records, the computer records, and tried to make it look like no amendment had been made. And I can tell you, no IT expert, but if you can imagine the sort of public-facing element of a clinical record, on a computer, you might be able to look like no amendment has been made, depending on the system. But you can be pretty sure that somewhere buried within that computer system is some code that's documented when someone went back in there and what amendment they made. And as I say, I've had 2 GDC investigations where IT experts have been instructed to establish that. And the reality of it is that when you start getting into that kind of territory, you're risking the GDC no longer criticizing your clinical records, but questioning your honesty, which is a far, far more serious thing, probably the most serious thing that you can be accused of by the GDC. So frankly, it is just not worth the risk. If you need to make an amendment to a patient's records, don't try and hide it, be completely transparent about it. You need to make a retrospective entry, mark it as such, make it clear that that's what you're doing. It's just not worth the risk doing anything else. If you refer a patient to another dental professional, keeping an accurate record, of course, we might all be thinking of external referrals, but it relates to internal referrals too, to other members of the dental team within the practice. You remember a minute ago I mentioned how the GDC used the words must and should at different times in different GDC standards. In these 2 examples, you'll see they're using the words must and should in the same standard, we're dealing with 2 separate sentences. So 2.3.6, you must give patients a written treatment plan. So it's a GDC requirement to give patients a written treatment plan before treatment starts and retain a copy. You should also ask a patient to sign the treatment plan. It's a good idea, even though there is a bit more wiggle room with that should, it's a good idea to do that. Keep a treatment plan and estimated costs under review. You must inform patients immediately if the treatment plan changes and provide them with an updated version in writing. I mean, it's not just, the benefit of doing this kind of thing isn't just, because it's good practice and it's a GDC requirement, but it also puts us in a good position, reduces the likelihood of misunderstandings or miscommunications with patients about costs, and reduces the likelihood of issues about that kind of thing. But it also puts us in a better position if down the line, let's say, we've got to consider debt recovery or something along those lines. If you've got a signed treatment plan by a patient, you can imagine you're in a stronger position if that's what you're faced with. NHS versus private treatment. Whenever you provide a treatment plan, it needs to include proposed cost, treatment, and whether or not it's being carried out under the NHS or privately. So some of you, I'm sure, will already be familiar with the GDPR. Came into effect in May 2018. And it was a new law that is involved in regulating and the processing of personal data. It gave patients, data subjects in this context, additional rights, including the right to access. It applies to all living patients and handwritten records. As I said at the beginning, these requirements apply equally to computer-generated and handwritten records. And there are 6 Data Protection Act principles. So the GDPR and the Data Protection Act 2018 came out at the same time. So these are the 6 principles of the Data Protection Act 2018. Information needs to be used fairly, lawfully, and transparently, used for specified and explicit purposes, used in a way that's adequate, relevant, and limited to only what's necessary, kept up to date and accurate, not kept for any longer than necessary, and handled in a way that ensures appropriate security. So many of you, particularly who are practice owners, will be familiar with the requirement to have a privacy policy at the practice, which will include different pieces of information for patients, including the lawful basis upon which you're processing their data, your retention period, so how long you're likely to retain a patient's records for. Also that individuals have the right to complain to the ICO if they think there's a problem. it's a good idea, and it may be something that, again, the practice owners in the audience might want to have a look at their privacy policy for. But it's prudent within the privacy policy to inform patients that if they make a complaint or a claim, that the practice might need to share information with the indemnity provider or legal advisors, and that sort of, makes it easier for you to confidently share, or more confidently share patient data with us if and when you're in that position. So as I mentioned a second ago, GDPR changed the expectation in relation to the retention of records, because it's that word necessary. Personal data should not be retained any longer than necessary. That was one of the principles. But there's no sort of universal definition of what necessary is, and instead it's down to the individual data controller to sort of illustrate how they've reached that decision in their dental practice in this case. Practice should know what records they hold and have a protocol for their retention. So that, gone are the days, and I can certainly think of one practice I worked in many years ago where there was a room out the back of the practice that had just shelves upon shelves of paper records, and no one sort of went in there very often, and certainly no one had much of an idea of what was in there and how long those records went back. That kind of scenario wouldn't be in line with the expectations of GDPR, because one of the requirements is you need, in order to be able to categorize and process data properly, you need to know, first of all, what you hold. And again, commonly practices will first of all establish what records they hold, and then from there, consider categorizing those records into different groups, and then obviously have a protocol for how long they're going to retain those records, perhaps dependent on which group or category those records fall into. So it's sort of that kind of way of approaching the retention of records is the requirement of and expectation of the GDPR. Some of you may know that NHS England have issued guidance stating that records should be retained for at least 11 years after the date of the last entry, or 25 years of age. The patient's 25 years of age, whichever is longer. That's something that can, that time frame can perhaps be incorporated into the sort of rationale behind the practice's record retention policy. So we're going to talk about what would make up the ideal record, if there is such a thing. Considering that, again, this is something that takes a lot of time and can feel like, over the years that it's sort of certainly become an increasingly onerous, perhaps, and certainly time-consuming part of our day-to-day lives as dental professionals. So the ideal record needs to be contemporaneous, clear, concise, accurate, complete, indication of who treated the patient. That might sound obvious, that last point, by the way. It's not always obvious with handwritten records, firstly. In an ideal, world, that handwritten records, you would be putting initials or the name of the treating clinician, so that's clear. It's not always clear. Even with computer records, it's not something to sort of just take for granted. And a good example of this is that, again, depending on the system, I had a case not long ago where the treatment in question was carried out by a locum dentist at the practice 3 or 4 years ago. And on the computer records, I think it was Software of Excellence, I can't remember, it doesn't really matter. Instead of having a clinician's initials, it just said locum. So 3 or 4 years ago, there were a handful of appointments that just said locum. And the practice owner, who was the DDU member, looked back at that period and thought, well, actually, I engaged with a few different locums actually at that point. I couldn't, with any confidence, say just on the basis of those records which one of these locums treated those patients on those days. So something worth bearing in mind. The other thing to consider is that if you're ever thinking about changing computer systems and moving data over from one system to another, before you press the button, you want to be pretty confident that all of the relevant data will be transferred. And this is obviously an important example that details of who the treating clinician was at the time of each of the appointments. This is an example of obviously of poor record keeping. Many of us might think this is a thing of the past. It's not necessarily. I would still see some handwritten records that don't look dissimilar to this. This is a particularly bad example, but there are some handwritten records, as I say, look pretty similar. But as you can imagine, it's, first of all, if this is how you were to write your clinical records, it can you're vulnerable to criticism, certainly, but also you're not putting yourself in as good a position as possible in relation to pushing back against that criticism. So, or criticism by a third party, be it a patient or anyone else. So records need to be legible. Handwritten records obviously are a good example of how legibility can be an issue. Perhaps this is an example. But it can also relate to computer records, and we've used the word intelligible here. An example of this, I would say, is orthodontic records. For those of us, including myself, who don't have much by way of orthodontic experience, reading orthodontic records can be a challenge at times. They're sort of set up differently. A lot of the acronyms that are used, again, if you don't have orthodontic knowledge like me, it can be difficult to sort of decipher and figure out what's happened and when and why, and even who the treating clinician was at that time. So worth bearing in mind. I mean, perhaps particularly as an example of orthodontics is just one example, but any dental profession who has a special interest or a specialty, the way that you're writing your notes might appear obvious to you and perhaps other members of the dental profession or other dental professionals who share that interest and knowledge, but aren't necessarily to everyone. So it's worth bearing that in mind, and trying different ways to ensure that the records are as intelligible as broadly as possible. Put yourself in as good a position as you can. Some of you may have heard the term responsible bodies. So responsible bodies of opinion is sort of a key phrase in the dento-legal world. And what that means is that in the UK, we all know that there's different ways of doing dentistry in the UK. And what a responsible body is a proper body within the UK that would issue guidance and standards. So, for example, the specialist societies, the royal colleges, these kind of bodies that issue guidance and standards. If you're ever in a position where a third party is trying to criticise you, the ideal position to be in is to be able to demonstrate that what you were doing was in line with one of these responsible bodies. That's the best way to to push back against an allegation of negligence, for example, or an allegation of fitness to practice concerns by the GDC. If you can demonstrate that what you were doing was in line with a responsible body of opinion, then you're on sort of relatively firm ground. And two examples of responsible bodies that have issued guidance for record keeping are the College of General Dentistry, used to be called the FGDP. So the College of General Dentistry standards on record keeping are available for free online. And another example, these are just two examples, another example is the NHS dental record keeping standards, the consensus approach, again available online. If you were to write your records in line with the standards of responsible bodies such as these, then you shouldn't be justifiably criticised. So it's worth having a look at this kind of thing and just sort of seeing what's expected of us and how we can put ourselves in the best position possible. Helpfully, in 2016, the College of General Dentistry standards were sort of updated, and sort of further detail was added as well as them being updated. And one of those further detail related to how certain parts of the records were considered to be basic. And the expectation would therefore be that they would generally be expected to be included. But others were considered not necessary to put in every single record, and instead were marked as aspirational and conditional, depending on the details. And that was a helpful development at the time, because prior to that, 2016, a critical third party could look at the College of General Dentistry standards, for example, and sort of suggest that if every single detail that was in there wasn't included in someone's records, i.e. the gold standard, then, for example, if it was a GDC investigation, an allegation of fitness to practice could be made. So again, this update in 2016 was a helpful development. So an ideal record needs to include, obviously, extraoral, intraoral, soft tissue, hard tissue, radiographs. Of course, there are specific requirements in relation to record keeping and radiographs. College of General Dentistry, for example, has separate guidance and standards dealing with radiographs that's worth looking at. Any special tests that were carried out. You'd include details of what the presenting complaint is: history, dental, medical, social. Social can be relevant in the context of gaining consent from a patient. Dental charting, including perio charting. Another example of a responsible body of opinion in relation to perio charting would obviously be the British Periodontal Society, and have issued guidance in relation to BPEs and when 6-point pocket charting would be required. Again, with radiographs, just justifying grading and reporting. And as I touched upon earlier, the discussions necessary to obtain valid consent is very, very important. And probably, again, the best evidence from a dento-legal perspective that consent has been obtained. And again, that should be being recorded in the records. So obviously, as you're going through your appointments, it would be the records would be documenting the treatment given, any mishaps and complications. A bit like what I was mentioning in relation to making amendments or retrospective entries to records. We all know as dental professionals that mishaps and complications are part and parcel of dentistry. Third parties generally accept that. The important thing is to be able to demonstrate, first and foremost, that you've been fully transparent with the patient about that. You'll have all heard of, I'm sure, the term your duty of candor, and what that relates to is that, again, the acceptance that complications and mishaps can happen, but we need to be completely honest with our patients about it when it does happen. And again, obviously, the chances are that we will do so as soon as we become aware of it, and that might be, verbally within the surgery. But it's a good idea to document in your notes that you've informed a patient of a particular mishap or complication, so there's no question about that down the line. And of course, the record should be dated and have an electronic signature or handwritten, depending on the details. So computerized records. Obviously, there are different things to think about in relation to the security, content, and confidentiality of records. Commonly, there will be a clause in staff contracts, both in relation to employed members of the team, but also self-employed members of the team. And there'll be a confidentiality clause in let's say, self-employed associates or self-employed hygienist therapist contracts. And a requirement to comply with the practice's policy on confidentiality, for example. But some of you may know that at the DDU we do provide a contract review service, and the most helpful time to use that service, I think, is, when you've been offered a contract that you haven't yet agreed to, and you're negotiating the terms of it. We'll read that contract and we'll give you lots of hopefully helpful, constructive advice. But in relation to something like this, and I've read a lot of these associate agreements and hygienist therapist agreements over the years, they'll commonly include a sort of a general requirement that the individual will comply with the confidentiality policy within the practice. And just one piece of pragmatic advice that we can give a member in that position is, look, before you agree to that and before you sign that contract indicating that you're willing to do that, you might want to ask for a copy of that policy so you know what it says, so you know what you're agreeing to. There can commonly be a confidentiality clause in a contract with others who access the computer. Different members of the team will have passwords and access levels. That can be a helpful thing in relation to, not all members of the practice team need to have full access to every part of a patient's records, and it can be helpful to, if questioned, to be able to demonstrate that that's how a practice is set up. Thinking about positioning, not compromising patient confidentiality, the obvious example of this is, computer screens in reception areas, and I suppose the surgery as well, facing away as much as possible, so that they're trying to avoid breaches of confidentiality where you can. Backup and IT recovery arrangements, commonly these things, as far as I'm aware, the practice owners among us will know more than I do about this, but the commonly software is backed up to the cloud now, as opposed to sort of physical hard drives, which is a positive thing from what I gather, as far as avoiding losing hard drives and the security of it all. And again, knowing what the archiving arrangements are for computer records and having a policy on that is probably a good idea. So are the records contemporaneous? I rewrote all the records which I sent to the DPB, Dental Practice Board, for clarity's sake. may seem hard to believe, but I've had a case not that long ago where that's what happened. And at the end of the day, it's just very, very important that you're never tempted to do something like that, because look, having your clinical record keeping criticised by a third party is one thing. Again, it's a very common allegation that can be made by the GDC, but it's what's called a remediable allegation, or it's a remediable criticism. And what that means is, just purely in the context of a GDC investigation, if the GDC were to make allegations of failure in record keeping against a registrant, what we would be advising that member to do would be, well, okay, do some CPD in record keeping, do some audits of your records in the practice, so that you can respond to the GDC in the way that in the best way possible. So what remediable means is, again, it's a bit of a GDC word, but if the concern can be remedied, so remediation, you're expected to carry out remediation. If the concern can be remedied, and certainly clinical record keeping concerns is a good example of a concern that can be remedied relatively straightforwardly by doing CPD, doing audits, incorporating the lessons learned into your practice and demonstrating that that's what's happened. If that's what you're faced with by your records being reviewed by a third party, it's not the end of the world. Whereas getting caught out for rewriting records because you're trying to sort of avoid that, or trying to avoid criticism, or you panic and think, well, I'm going to rewrite them before I send them off. Completely different kettle of fish, because you'd then be accused of dishonesty. And as I said earlier, that's the most difficult thing and the most serious thing to be accused of, because the GDC, rightly or wrongly, view dishonesty as something that can't be remediated. You're either an honest person or you're not. So an important point to take away. Also, be careful with abbreviations. Some of you, I'm sure, will be familiar with. You have a guess at what these abbreviations stand for? I'll let you have a guess at what you think that abbreviation might stand for. This this slide is a good prompt for another couple of reasons, and one of them is, again, just remember that whenever you're writing your records, again, I've been talking a lot about third parties and the GDC looking at our records and all that kind of thing. Remember that the most obvious person who could be reading your records is the patient themselves. So anything you write in your records could be viewed by the patient themselves at any point. And certainly in my experience, patients are very aware these days. I mean, I think it's probably because, GDPR and all that kind of stuff got a lot of press when it all happened nearly 10 years ago. So, your average patient is a lot more aware these days than perhaps patients once were about their rights as data subjects and all this kind of thing. So patients will quite commonly, ask for copies of their records. I spoke to a dentist recently who said that in their experiences, commonly younger patients will, as a matter of course, ask for a copy of their records after their appointment because they want to know what they say. So again, it's just being alive to the fact that, avoiding writing anything in a patient's records that you think could be inflammatory if the patient were to read it. Also in the context of, being careful with auto notes. Let's say, for example, you were to use an auto note for the consent discussions. The patient, all these different things were discussed and patient was warned of all X, Y, and Z. Then the patient requests a copy of their records and sort of queries, hang on a minute, I wasn't there for that discussion. What's this about? And it can be sort of an awkward, slightly embarrassing complaint to have to respond to because you've got to sort of acknowledge that it was an unamended template and all this kind of thing. But just finally, in relation to this slide, is that if patients do request their records, and certainly again in my experience, patients are far more willing and able to do that than they perhaps once were. It doesn't necessarily mean that it's something to worry about. Again, patients can request their records or copy of their records for any reason. It doesn't necessarily mean that they're going to make a complaint or a claim or anything else. And so, look, at the end of the day, under the GDPR, patients have got a right to a copy of their records within a calendar month. Is an interesting detail from the GDPR. It's not a specific number of days, so a calendar month's obviously different in February to other months of the year. But again, in my experience, it's a good idea if a patient requests a copy of their records, make them available to them, without any unnecessary delay. By a secure means, and it's not necessarily something you need to worry about. So an ideal record, again, includes a diagnosis, communicating it to the patient and then recording it. It comes back to what we said at the beginning about remembering that the primary purpose of records is clinical and not dento-legal. So again, if we approach our clinical record keeping by communicating to the patient first and foremost in the surgery, recording that clearly and accurately in the records, then again, that actually, from a dento-legal perspective, puts us in the best possible position. So as we've said, try not to hide errors, try not to disguise additions to notes, and try to avoid offensive, personal, humorous comments about patients. Written treatment plans and fee estimates, as we've seen, is not only a GDC requirement, it's also a requirement of the NHS regulations. They can be an important piece of the record in relation to clinical negligence claims and breach of contract claims made by patients. But again, as I've said earlier, it's not just about the patient making claims or criticism of us. It actually having a signed treatment plan, a written treatment plan, ideally signed and retained in the records, puts us in a better position if we ever need to consider debt recovery, and again would reduce the likelihood of a misunderstanding and a subsequent over the cost of treatment and a subsequent debt. If the costs of treatment have been very clearly presented to a patient in writing, there's a signature there, and that can all be demonstrated. Going through that process reduces the likelihood of debt, of bad debts, and should put us in a better position in the context of debt recovery too. So again, it's not just beneficial to patients, it's beneficial to us. So using templates wisely, this is important because, again, as I've said, and particularly those of us who use computer records, it can feel like there's a lot to cover and there's a lot of different things to remember. And having a skeleton template that we then complete and amend can be a very helpful tool and a very helpful as an aid memoir. But the problem is, if they're pre-completed, it will likely lead to errors. We all know that inevitably, with time pressures, patients running late, us running late, we've all had those days where it can be very difficult to always remember to go back in and amend pre-completed templates accurately. So you're a hostage to fortune, to eventually that leading to errors. So it's something to try and think about. By all means, using templates, but if they're pre-completed, it's a risk. And a good example of this is in relation to, again, as I've touched upon, using an auto note for the discussions necessary to achieve consent. If you can imagine that if you're using a pre-completed template detailing a big paragraph of warnings and discussions with a patient, and that paragraph appears exactly unamended in exactly the same way over the course of multiple appointments, it doesn't take much to imagine a clever or critical third party querying what's the likelihood that that note is accurate. So again, if there's the same note appearing multiple times, the accuracy of the records can be questioned. Being careful with AI, again, this is obviously a relatively new thing in the dental world, but it's increasingly popular and increasingly becoming an increasing part of many dental professionals' lives. There are obviously different systems. They all work in slightly different ways, but ultimately you've got to remember that even if you were to be using an AI record system, the same principles apply, the same requirements apply. They need to be accurate, and ultimately it's our responsibility as the treating clinician to check the accuracy of the records, irrespective of how they're being generated and by who. So in summary, no notes can equal a difficult defense. Interestingly enough, it doesn't necessarily mean no defense in the context of a claim for compensation, for example. It's not necessarily always as simple as that. Some of you may have heard the terms that are relevant in the context of a claim for compensation: breach of duty and causation. So in order for a patient to have a valid claim for compensation, they need to demonstrate that they've suffered avoidable harm as a result of a breach of duty of care from the dental professional. And now, obviously, not having any notes doesn't help. But when a claim for compensation is being assessed, it might be that the independent expert looking at the previous dentist's records and the subsequent dentist's records might be able to give an opinion on whether or not that legal test has been met, based purely on those records, just by way of an example. But the reality is, of course, having good, accurate records helps from a defence perspective. Remember, of course, that when we're treating a patient, it's a unique event for the patient. Those of us who have family members who aren't dental professionals will know this when they go to see a dentist. It's a very strange atmosphere, very alien atmosphere, and they remember all sorts of details. Where, of course, when we're the dental professional, we're treating however many patients a day, day in, day out, week in, week out, it can be much harder for us to remember the details. So it's very important, therefore, that our clinical records are accurate, reflecting the specific details of our interactions with that individual patient and what was discussed, and particularly in relation to complications and problems. there's more information about all of this stuff, or a lot of it, on the DDU website. My colleague Cam is going to put a link to our website in the link box, which you should all have access to. And as I say, there's more information on our website about record keeping, about GDPR, and by all means, if anyone has got any questions, I'm going to run through some of them now that have come into the Q&A box. But by all means, if by all means, you can obviously get in touch with us afterwards. How detailed should the prescription to the hygienist be? I think that it's, the prescription should really contain as much detail as possible. Obviously, I suppose it depends what the treatment prescription is going to be for. And so, of course, the devil's in the detail in relation to that. But I would expect, for example, it's going to include, the site, whether local anaesthetic is being prescribed for, and of course, as we all know, there have been developments in relation to that. The site, which specific treatment is being prescribed. So I suppose, as I say, it depends very much on the actual treatment prescription, the actual treatment that's being prescribed as to how detailed it needs to be. But it certainly needs to be more than just please see and treat, and all this kind of thing. I've certainly seen examples of that. There's very little detail in the records by the referring dentist, and the treating hygienist is sort of unclear what treatment is being requested. And frankly, if you're ever in a position like that, then you should be going back and asking for more detail from the dentist. You shouldn't be proceeding, based on on guesswork, or not really being sure. So frankly, if you don't think that the prescription to you as a hygienist treating patients on a referral is detailed enough, or you think you don't have sufficient detail, then you should be going back and asking. It's stated that all courses of treatment should have a written treatment plan. Surely this cannot mean for simple treatments like a scale and polish. My understanding is that it does. That you would be expected to, if you're carrying out a scale and polish for a patient, and obviously, even onto the NHS, paying patients will be expected to pay a band 1 fee for that. Then they should be provided with a written treatment plan. If you leave the practice and the practice doesn't retain the records, if we get a patient complaint, then who's at fault for not maintaining the records? Well, obviously, if you've left the practice and they haven't retained the records, well, that's obviously beyond your control. As I say, I have had cases over the years where, for whatever reason, the records haven't been locatable, and the practice haven't been able to provide a full copy. But yeah, look, as I say, if you're a treating clinician and you contact a former practice and they no longer have the patient records, as long as that's, as long as you can demonstrate that you've cooperated and done everything that's within your power to to be constructive and move forward. Well, as I say, if the practice have destroyed the records already, that's beyond your control. How do you find a balance between concise notes and enough details to cover our backs, so the note is clear enough for the important details, but not like a minute or minute? Because someone suggested that if it's not in the notes, it did not happen. But then it can feel like a note will be defensive. In fairness, I do think there's been some sort of positive developments in relation to that point. It's not as simple as if it's not in the notes, it did not happen. And I think, again, from memory, there's been some helpful case law that has sort of moved that forward and established and demonstrated that, frankly, it's not as simple as that. For example, let's say you're responding to a complaint, and this is commonly something that we would be advising members with when we're helping people respond to complaints. obviously, it's ideal if you need to refer to a specific detail that's relevant to be able to say it's in my notes. But as you sort of said, it's not realistic, and you can't write everything down all the time. It's unrealistic to expect that, and as you said, if you try to, you're going to start, writing your notes in a defensive way. And as I've touched upon with auto notes and all the rest of it, you can end up shooting yourself in the foot. So I think at the end of the day, I think there's a degree of sort of professional judgment that needs to be applied in relation to how much detail you feel you need to go into beyond, of course, looking at the likes of the College of General Dentistry standards, the NHS standards I gave examples of. Those should be your sort of reference point as far as what needs to be in the notes. But again, I would reassure everyone listening that it's not as simple as if it's not in the notes, it didn't happen. Because again, when we're responding to a complaint, again, it can be helpful if you're able to, in the response to a complaint, say, my clinical records of the 6th of June 2024 show that we discussed or I informed you, but it might not be the case. So instead of that, you might be using phrases such as, on the 6th of June 2024, I remember that we discussed X, Y, and Z, or it is my recollection that I warned you of A, B, or C. So no, I think that if you're trying to write down every last detail in the fear that if it's not written down, it didn't happen, then I think you'll be chasing your tail and end up shooting yourself in the foot. What do you think of using AI software in record keeping? I think I touched on that briefly. I think, look, at the end of the day, again, different systems, and I'm aware of some of the different systems and how they can work differently. And look, of course, there's an element of finding what depends what your practice is using, and if you're a practice owner, maybe looking at different systems and trying to establish how they work, so you understand that, and choosing the right system for you. So it's not a sort of overarching rule beyond. You've just got to remember that the same expectation of accuracy applies in relation to any records you're writing, be it handwritten or AI assisted. And again, it's our responsibility. And I'll give you an example. I was at a lecture a while ago that was talking about AI software, and they gave the example of how you referred to giving oral hygiene instruction, and it pre-populated a big paragraph about oral hygiene, what oral hygiene instruction was given to that patient, just off the trigger of using the word oral hygiene instruction. Well, of course, that's almost like an auto note, isn't it? Which, as we've said, you're hostage to fortune as to whether or not that's actually going to be accurate. So it comes back to, again, just being careful, remembering that again, it's our responsibility to check, and it's our responsibility that they're accurate. If the accuracy was questioned down the line, it wouldn't be sufficient to say, well, it was AI software, so it was beyond my control. Just bear with me, guys. There's quite a few questions coming. I may not be able to get to all of them, but I'll take a couple more. Does entering VCO verbal consent obtained on my notes count as good enough consent? I work alone as a hygienist, and does the Clinipad signature count for this? Remember that when it comes to consent forms, and again, Amanda, you might want to have a look it's on our website, the webinar that we did on consent, because it kind of goes into, it's a separate subject and goes into that in more detail. But just very briefly, it's only a GDC requirement to use a consent form for sedation and general anesthesia. Using a consent form can be a helpful piece of evidence as far as additional evidence if the consent process is questioned, but it should never be a substitute for having that two-way discussion that we're all having with our patients day in, day out. So with regard to, and again, that's of course, the vast majority of consent given by patients for dental treatment in the UK is done on the basis of verbal consent. And yeah, but the the best evidence from a record keeping perspective is an accurate, and it doesn't have to be massively detailed. Another word that's used in relation to all of this stuff, by the way, is succinct. Records can be sort of, sufficiently detailed, but also succinct. But if you've got a good note, again, it doesn't have to be massively detailed, illustrating that two-way discussion that you've had with the patient in the process of gaining their consent. That's the best. That's the best evidence from a dento-legal perspective that you've gained consent from that patient. If you practice in the UK for a few years and then decide to move abroad, does the DDU still defend a former member? Slightly non-record keeping question, but the short answer is yes. If you were a member of ours in the correct category at the time of the incident in question, you can request our assistance. There's no time limit. That's what occurrence-based indemnity means. This is Alison Grant just visited the College of General Dentistry. Free access to guidance is only available for College of General Dentistry. Yes, that's true, but you can join as you can register for free on the CG Dent website. So you need to create an account and a password, but you can do that for free. I'll take one more question. If you have not gotten a complaint, but in order to avoid a complaint, offered and gave a patient a refund, this has to be placed in the notes as per advice of colleagues. Is that defensible, the right thing to do? I think I know what you mean. The couple of things to say. First of all, if a patient requests a refund, you don't have to give a refund. It's very, in my experience, case dependent. We all know that, the fees that we earn as dental professionals are hard earned, is a phrase that a member used to me recently, and I couldn't agree more. Dentistry is hard work, and when a patient requests a refund, whether or not that's the appropriate, wise, fair thing to do under the circumstances is very much a personal decision, and very much based on the individual circumstances. That's the first part of the answer, I think. The second part of the answer, I suppose, is that if you are going to give a patient a refund, even if you think, albeit reluctantly, that in the interest of trying to resolve the complaint under the circumstances, you are willing to do that, you want to be pretty confident, or as confident as you can be, that that's going to resolve the matter. Because what you don't want is to give a patient a refund to resolve their complaint and then they come back for more the following week. It can be, gaining that understanding. Can you keep a note of that in the records? Yeah, but you can also, do it in writing, and that's the kind of thing that we can help with. If it's a very simple form of words, it might be something that we can help with just over the phone on the advice line, or perhaps instead, you might want to send some information into us. But that's the kind of thing that we help members with, day in, day out, is providing written correspondence to offer a goodwill gesture, if that's what you're willing to do, on the understanding it's going to resolve the matter. But yeah, it's a good idea, particularly if it's a significant refund in any way, to get written confirmation that that's the end of it. So that's it. So thank you very much, everyone, for your time this evening. Yeah, as I say, there's more information on our website. If anyone has any, further questions going forward, we'll be able to answer them. And yeah, you will be receiving your CPD certificates in due course. So thank you again for your time.